For our second talk, I'll again have to request Professor Quinton, who is a recipient of Ralph Nobel Prize by University of Cambridge and Outstanding Clinical Practitioner Award by Society of Endocrinology, and is actually an expert in reproductive endocrinology. He'll talk about diabetes and sexual disorder. Thank you, sir.
So many thanks again for that generous introduction. I loved Atul's talk. Did you notice he's gone native? He's developed a faint Welsh accent and cadence. I loved it. You have to maneuver him. You have to ask him a question to which he's forced to answer. It's not unusual. He'll tell you about that later. So this is the embarrassing talk to give in front of my wife, because she always says, Richard, but you know nothing about diabetes. I haven't done diabetes clinics for many years. But one thing I can say is that in the same way that diabetes clinics are enriched, if you may say that, with endocrine disease, so endocrine clinics are packed full of people with pre-diabetes. So why is this? This is things I'm going to go through in this area are why the topic is important. A little bit about antihypertensive drugs and erectile dysfunction, just to give you some top easy tips. I love low-hanging fruit, easy things to enact. Male hypergonadism and how to identify it in the diabetes clinic. Androgen-induced erythrocytosis, why it matters, how to manage it, and how the SGLT2 inhibitors may begin to contribute to this. A couple of special topics, genetic hemochromatosis and relative energy deficit, which you sometimes see in terms of diabulimia. Some discussion about sexual function and hypergonadism in women with diabetes. Again, the rough guide to HRT in women with diabetes. What I'm not going to cover is second-line urological treatments, such as Caboject for male ED, when Viagra and Cialis tadalafil won't work. And I'm also not going to cover the approach to the culturally appropriate initiation of this discussion about sexual issues with patients in clinic in Pakistan, for instance, because you will have seen the marvelous YouTube videos, Dr. Professor Raza at Lahore, where how he describes how to initiate the discussion in a sensitive and culturally appropriate manner. But I have to say, how any patient can take sexual health advice from a guy who still looks 16 years old, I've no idea, but it must be his natural authority. Unlike myself and Professor Ali Jawa, he still has jet black hair and looks youthful. So why is sex important for patients with diabetes? Well, it's part of the glue that hold couples and families together. And increasingly, both partners may be affected with diabetes. And there are quite strong associations of having regular sex with personal happiness, general health, quality of life, family relationships, and disease-free longevity. And in men particularly, the onset of sexual dysfunction signposts a higher cardiovascular risk. In women with diabetes, it may be the first sign of underlying depression. But paradoxically, it may also arise as a direct consequence of drug treatment for primary depression. We know the drugs for depression are very good, but they can predispose to low libido and anorgasmia. Interestingly, being married is associated with lower HbA1c for UK men and women aged 50 plus years, not having diabetes at baseline. And actually, a rising HbA1c is associated with increased risk of divorce. And in the USA, men who are divorced or separated and women who are widowed are a higher risk for diabetes-related mortality, and especially so amongst ethnic minorities. So, antihypertensive drugs and erectile function. So ED is twice as common in hypertensive men than in normotensives. And that's even when you account for other confounders such as age, smoking, or diabetes. And roughly speaking, in hypertension, you start off having a relatively vasoconstricted vasculature, and that's why the pressure goes up. So narrower lumen. And men with ED are around 40% more likely to have hypertension than men without ED. And it may be exacerbated by many of the older antihypertensive drugs, particularly diuretics, which cause volume depletion, beta blockers, and calcium channel blockers. And of course, remember spironolactone, fantastic drug, absolute lifesaver in certain conditions, good for heart failure, but it blocks both testosterone secretion and also testosterone action at the androgen receptor. Hence, actually, it's extensively used in the treatment of transgender females. And also, with calcium channel blockers, often because they cause edema, particularly the higher doses, then some will put in a diuretic as well to try and manage that edema. On the other hand, having undertreated heart failure is associated with even worse ED. So to get the balance of treatment right is useful. So what are the preferred drugs? Your preferred drugs really would be the vasodilators, ACE inhibitors, angiotensin receptor blockers, and alpha blockers, which may actually even improve ED slightly. But really, this is the interesting thing, ED is in the small print of almost all drugs. And we're always told to be honest with our patients, but actually, with ED, if you tell a patient that it's a side effect of the drug, potential side effect, you actually greatly increase the chance of the patient experiencing that ED. So it's like the nocebo effect. So in this case, it's one of the things where you're justified actually in withholding the information, because by being honest, you actually make it more likely that they will experience the undesired actuality. As said, diabetes clinics are enriched with patients with undiagnosed hypogonadism, and of course, hypogonadism can predispose to sexual dysfunction. So how might patient be identified? Well, of course, most of you will note, yes, of course, that sexual symptoms uncovered on questioning at annual review. There may be low libido or sexual dysfunction that's refractory to first-line therapy with Viagra or similar drugs. But remember, there are also non-sexual symptoms: flushing, sweating, painful gynecomastia. And this is the one thing I want you to remember. You see a man in the diabetes clinic and they have normocytic anemia. There's quite a high likelihood that the cause of that is hypogonadism, because lacking the effect of testosterone erythropoiesis, effectively their hematocrit falls into what's the normal range for females. Things like history of fragility fracture or previous cancer treatments, which may be sometimes lost in the previous records. So what bloods are you going to do? Your simple basal bloods would be fasted at 9 a.m. That's to really improve your signal-to-noise ratio and to try and get as few borderline cases as possible. I would do LH-FSH, testosterone, binding globulin, and probably prolactin. But of course, if this is all normal and if you excluded hypogonadism, then the PDE5 inhibitors are really safe and very cheap drugs. In the UK, you can buy them over the counter. They're kind of virtually potentially a lifestyle drug. So how do we classify hypogonadism? It's basically either the light bulb broken or the light switch is off. Light bulb broken, really easy to diagnose because they've got high levels of LH and FSH. And so you can pick that up on a random blood test done at any time without clinical correlation. These individuals, biological fit, it's very easy to diagnose, but fertility, very difficult to achieve. You're looking at microtesticular surgery. Light switch off, this is much harder to distinguish from non-gonadal illness or things like a post-lunch venipuncture or someone taking anabolics on the quiet. And really, you really want to get 2 fasted 9 AM blood samples to identify this. But crucially, fertility is potentially restorable with gonadotropins, about which I will talk to you tomorrow. What about, people describe a syndrome of late onset hypogonadism. This is low testosterone, low LH and FSH, or low normal. But there's no underlying classical cause. There's no sort of pituitary tumor. They're not on opiates. They haven't had pituitary surgery. They've got no congenital syndrome. And these are great data from the European Male Aging Study. And we divide it into quadrants. We see bottom right, men who are normal. They got normal testosterone and normal LH. And then top left, men who are unequivocally abnormal. They've got primary gonadal failure, and that's about 2% of men over the age of 40. And then top right, you've got men with so-called compensated hypogonadism. in the sense the testosterone level is normal, but their LH is high. And then bottom left, people talk about, well, secondary hypogonadism, LH is low, testosterone low, but that's a biochemical diagnosis. If you drill down to the EMAS criteria for do you have 3+ sexual symptoms, then actually you're looking really at 2.2% of men over the age of 40. So really, combining the two, if you put in your secondary hypogonadism with symptoms and your primary hypogonadism, you're looking at maybe 4% of men over the age of 40. And then plus an extra 10% whose testes are beginning to fail with a high LH. And really, the ones with low LH, that's BMI and comorbidities. That's not age. That's disconnected from chronology. It just happens that as you get older, you gain more comorbidities, you get more obese, you take more medication. And when you exclude for all these, there is absolutely no correlation with chronological age. However, with the high LH, whether compensated or not, that is part chronology and part comorbidity. So there is a primary chronological correlation there. And what's interesting about compensated is, well, again, that's a biochemical diagnosis, but actually, if you've got anemia, osteoporosis, painful gynecomastia, or refractory sexual dysfunction, I put it to you, just how compensated is that? And actually, I see no problem with giving such men a trial of testosterone treatment. I think in the diagnosis of hypogonadism, a high LH is an absolute game changer. It says, there is something wrong with this man's testes. Yep, you can't take that away. And generally speaking, when the testes begin to fail, the track is downwards. Now, what's really interesting is that if you've got a high LH, it doesn't matter whether your testosterone is normal or not, you've just trebled your risk of having type 2 diabetes. And that applies through the rarest syndromes, dystrophia myotonica, Klinefelter syndrome, or age-related. And what we don't know is the direction of causation. But anyhow, you would expect to have a threefold rate of primary gonadal failure and compensated in a diabetes clinic compared to the general male population. And this isn't just ethnicity related, so it's SPECT China study, same data, very similar data. The only exception for the Han Chinese is that they're very old men, the 70s and 80s. They are tough as whipcords, all muscle, no body fat. They didn't adopt Western diets. They survived the Communist Party, Chairman Mao, Cultural Revolution, mass famine, and they're slim and fit, and they do their Tai Chi, and their testosterone levels are similar to those of younger Chinese men. Actually, they're better than those of middle-aged Chinese men. So I think late onset hypogonadism was initially hypothesized to be a form of hypogonadism where there was a low LH and there was no obvious classical cause, and based on needing 3 symptoms. But really, I think that for me, what's really striking is that very small proportion of men with full-on primary testicular insufficiency who go absolutely undiagnosed. So in 25 years, as an endocrinologist in Newcastle, do you know how many men with hypogonadism I was referred by the geriatricians in my hospital? 0, a round number, not one. And we will be finding men in the geriatric-run osteoporosis clinics, in hematology clinics with unexplained anemia. There is just no concept out there that actually having something like a low hematocrit, the chances of getting a pickup that they've got a low testosterone, high LH, is probably greater than they'll have a low ferritin. But importantly, the depressing slide which shows that the decline in testosterone with age, that overwhelmingly affects accumulating non-gonadal illness, particularly obesity, and comorbidities, with absolutely no direct impact of chronological aging. So yes, the male menopause, andropause does exist, but it's extremely rare. and there's a much higher rate of diabetes, type 2 diabetes. So the kind of low testosterone without raised FSH, it's ubiquitous in all chronic diseases, including type 2 diabetes, obesity, metabolic syndrome. And we wonder, well, is this really hypogonadism? Is there anemia? Is there low bone density? Are there smaller testes? And you obviously need to screen for peritonimas, hemochromatosis, and wider hyperpituitarism. Consider the possibility of obstructive sleep apnea syndrome. And really, what is the Rolls-Royce treatment that delivers the full range of benefits, including lower blood pressure, improved quality of life, and improved psychosocial function? Well, that's weight loss. You know, as you're with greater percentage weight loss, so your total testosterone level goes up. Now, what if you start treating these men with testosterone, these overweight men, obese men, with slightly low testosterone, with androgens? What happens? So there is a slight but definite improvement in sexual function. But that just may be, you know, I get half an extra sexual thought per week. It's modest. There is no improvement in perception of health, nor in physical activity or physical function, unless you were anemic at baseline, in which case there's a good improvement. So I've told you your first game changer, the LH level. Your second game changer is their anemia. You will improve their bone density, but you will increase their risk of fracture. The fractures aren't fragility fractures, they're activity fractures. And they start within the lines diverge within 3 months of starting. So that can't be a bad thing from bone density. It must be some behavioral issue. If you give very high dose testosterone, such that you can have a very high risk of erythrocytosis, and you combine that with lifestyle change, then you do reduce the risk of the development of type 2 diabetes. You may even reverse it. But regular dose testosterone without additional lifestyle change will not affect that. So, primary hypogonadism is really easy to diagnose. There's no need to even repeat the fasting bloods. There is an increased association with type 2 diabetes, uncertain direction of causation. And also we know, interestingly, that having a high LH is associated with increased all-cause mortality. So amongst your diabetes clinic, your type 2 clinics, you are going to have a lot of undiagnosed men with hypogonadism. And I would ask you, don't just ask them about sexual symptoms, to which for an old man, one of the answers could be, mind your own business, doctor. Look at the ones who are anemic. A lot of people had full blood counts done, someone else requested them. Look at those results. And just to say, if you've got primary gonadal failure, testosterone treatment is mandatory. Doesn't matter how old you are, doesn't matter what physical and mental disability you have, it's mandatory and it should always be prescribed, and an offer should never be withheld. What about for men with sort of obesity-related, slightly low testosterone? Well, we know that there's no increased risk of cardiovascular disease, stroke, or prostate cancer in the medium term if you choose to treat them with testosterone. There are only modest improvements in sexual function. There is no improvement in vitality or physical performance unless the hemoglobin was low at baseline, in which case there are real improvements. Glycemic control, it's not going to be improved with standard dose testosterone. But, you know, it's worth considering if you've got ED refractory to first-line therapy with Viagra, and if you've got androgen deficiency anemia, or if you've got low bone density or history of fragility fracture. But you might need to consider, actually, do I also need to give a bone strengthening drug? And the only one with fracture outcome data in males is IV zoledronic acid. In monitoring treatment of these men, your priorities, keep the hematocrit normal. Try and keep them happy, but number one, keep the hematocrit normal. Maintain normal range total and or maybe free testosterone levels. Intramuscular treatment, you're aiming to achieve low normal levels at trough, or in the UK or in the US, mid-range levels at the injection midpoint. Other things being equal. Other things aren't always equal. If the hematocrit's high, you have to drop the dose. Assess bone density by DEXA. Consider adding second-line treatment if there's osteoporosis. prostate safety, the SFE recommends that you follow national guidelines for the general male population, which in the UK is no screening in the absence of symptoms. Why should we worry about erythrocytosis? This is data from Scandinavia, 2 general population studies. Tromsø, Norway, showed a 50% increased risk of thrombosis and a 2.4 times increased risk of unprovoked thrombosis in men with a higher hematocrit, even when you adjusted for other factors. In Copenhagen, Denmark, the top 5% for hematocrit had 50% increased risk of coronary events compared to the middle 50 centiles. So that's why it's important, don't let the hematocrit rise. So I said I'd talk about some special situations, and I will talk about genetic hemochromatosis associated with HFE gene mutations. So why is this in the human population? Well, heterozygotes have an evolutionary advantage with dietary iron deficiency. They're kind of taller because they really can scavenge iron. But homozygotes, or compound heterozygotes, are predisposed to tissue iron overload. So if you carry the mutations, not everyone will develop biochemical iron overload, and if those develop biochemical iron overload, not all will develop tissue iron overload. And the overload is generally expressed in tissues or cells that have high levels of a membrane iron transporter. So beta cells, pancreas, liver, heart, joints, or the gonadotrophs in the pituitary gland. And alcohol predisposes the phenotype, and menstruating women are relatively protected. And your primary treatment is regular venesection to deplete tissue iron stores as soon as you can. But of course, the sooner you get the ferritin down, the better the outcomes are. But of course, you can't venesect someone until they faint, so you're limited by their hemoglobin level. You can't let them be symptomatic anemic. So if you've got HFE diabetes, you have a game changer. Give them as much testosterone as they can take to stimulate hematopoiesis, and you will burn through the iron stores faster, and you'll be able to venesect them more often, and you'll be able to protect their tissues faster. And of course, if you add an SGLT2 inhibitor, which also has a direct effect to improve hematopoiesis, then actually you can venesect even that much faster with combined treatment. And so both drugs independently promote hematopoiesis. And so the other special situation I was going to talk about was relative energy deficit, secondary hypogonadism. Now, that's far more common in females, although it's increasingly recognized in males. In females, we know about hypothalamic amenorrhea from dietary restriction, stress, and/or excessive exercise. And it overlaps the milder end of the anorexia nervosa spectrum. If the exercise effect predominates, then you may actually preserve your bone density, but compared to women who are kind of anorexics or simply underweight. But sexual function will just fall off a cliff in all cases. And we know there's 100% response to lifestyle change if this can be achieved. And so our consensus in the SFE is that there's a limit to how long you're going to drag on lifestyle change. You cannot simply allow a woman to go on for like years and years under pure psychological treatment when her bones and sexual function are at risk. So we suggest that HRT, not the combined pill, should be offered at the immediate outset in women who have no intention or capacity to alter their lifestyle or have not responded to lifestyle change by 6 months from intervention. Now, for men, we have no intervention data. And actually, if you're a professional athlete, WADA will not permit you to have testosterone treatment if exercise was the cause of your hypogonadism. But it's allowed for women. We think about sexual function as being more of an issue for men with diabetes. There are also issues for women. So we know that having diabetes is an independent predictor of female orgasmic dysfunction, although actually depressive symptoms and partner-related factors are stronger predictors. So obviously, clearly, if your partner is a lazy slob, your man doesn't wash, then that's it's a bit off-putting, really. But insulin seems to play an adverse role. So in a US survey, of nearly 1,500 sexually active women, of whom 20% had diabetes and 6.1% were on insulin. These are postmenopausal women. So the rate of low sexual satisfaction was significantly higher in diabetics, in women with diabetes, but especially higher, more than 1/3, in those who had diabetes treated with insulin. And for all women with diabetes, having an end organ complication, cardiovascular, renal, or neuropathy, for instance, was associated with decreased sexual function in at least one domain. And women on insulin were most likely to report problems with lubrication and orgasm. Okay, so I just have one thing to say about lubrication. And I think I speak for every man in the audience here. And so I promise you that if sex were remotely painful for us men, it would end tomorrow. The end. But yet we kind of normalize dyspareunia as being, oh, she had a bit of dyspareunia. Well, you try having that and see how much you want to. So lubrication, extremely important. And it may also be very important for older women in a non-sexual way. So I don't know about here in Pakistan, but in the UK, hospitals are full of elderly ladies admitted with delirium because triggered by urinary tract infection. And then, of course, you treat the UTI, and then they get delirium triggered by being in hospital. And so it goes. So we know that regular vaginal estrogen in even much older women can greatly reduce their risk of UTI and admission to hospital. So important even outside the sexual framework. So female hypergonadism in the diabetes clinic. So median age of menopause in the UK is 51 years. 40 to 45 we call early menopause. 40% increase cardiovascular risk to age 60. Under 40 years, we know as POI, there's an 80% increased cardiovascular risk. Now, secondary hypergonadism, which is amenorrhea lasting more than 3 to 6 months with low estradiol and FSH not raised, in young women, that's most commonly hypothalamic amenorrhea. Obviously, in there will be some pituitary tumors, but the vast majority will be hypothalamic amenorrhea. And I put to you the estradiol level. Lots of guidelines of female hypergonadism talk about women having a low estradiol level without saying what it is. Well, SFE nailed its flag to the mast and said, in the context of prolonged amenorrhea, an estradiol level under 200 picomole per liter is low and suggests hypergonadism. That's about under 50 of your American units. So for POI and for secondary hypergonadism, HRT is mandatory. For early menopause, it should be encouraged. And for menopause, it's based on informed discussion and shared decision-making. But really, vaginal estrogen should always be recommended to almost any woman past the menopause because its effect also in older age. And having diabetes is definitely not even a relative contraindication to HRT in women. Now, some of you have seen the, on an estradiol lab printout, you get the world's most useless normative range because you get all these estradiol levels according to his early follicular, late follicular, luteal, and you think, what is this? And it's a complete load of meaningless drivel. Because if the woman was having regular periods, you wouldn't have checked an estradiol level in the first place. All you need to know is less than 200 suggests you might have hypergonadism. And lots of women, you think you knew why they were amenorrheic. They're known PCOS. They've had a hysterectomy. They have a Mirena coil. They're on the progesterone-only pill, Depo-Provera, Nexplanon. But do they have sexual symptoms? Low libido, vaginal dryness, or dyspareunia? Do they have vasomotor symptoms? Flushing, sweating, or disrupted sleep? And if they have known PCOS, forget about what the ovary looks like. What did the endometrium look like? If the endometrium was less than 3 millimeters, that's hypergonadism, unless you're on progesterone contraceptive. That's not consistent with PCOS. And so consider diagnosing and treating hypergonadism if there's low estradiol level, or raised FSH, or the kind of thin endometrium in known PCOS, and particularly if there's been sexual or vasomotor symptoms or fragility fracture. So what's the difference between combined oral pill and HRT? Well, combined oral contraceptive classically comprises ethinyl estradiol, synthetic estrogen, and a progesterone. 21 days combined treatment, take a week gap, have your bleed, restart. Sequential HRT, the estrogen is actually continuous. You have to take it all the time. And the progesterone, 14 days a month usually. Stop the progesterone, estrogen only, have your bleed, restart. So the estrogen is continuous, there's no gap. It's the progesterone that's on, off, on, off. Continuous combined HRT is really the same dose of progesterone, but spread more thinly over the entire period. Or even better, it can be a Mirena intrauterine system, which gives very good individual protection. So here are your various HRT delivery systems, oral, patch, gel, spray, Tibolone really we only tend to use as a last resort, and here's the marvelous little Mirena coil. So just some basic troubleshooting for HRT in women with diabetes. Any woman with dryness, dyspareunia, or UTIs, give them vaginal estrogen, even if they perhaps decline systemic estrogen. Obviously, consider candidiasis, especially with SGLT2 inhibitors. Your risk of thromboembolism is greatly reduced if you're using transdermal estrogen, and your risk is highest if you're using the combined pill. The risk also increased, unfortunately, with GLP-1 analogs, so think about that. Avoid HRT within 6 to 12 months of MI or stroke, and thereafter transdermal. And always go for transdermal with obesity, smoking, thrombosis, cardiovascular disease, migraine, or GLP-1 analog. And for goodness sake, avoid American-style horse estrogen, Premarin. That has a much greater risk of thrombosis than natural estradiol. In terms of your progesterones, either use the metabolically favorable ones, like progesterone or dydrogesterone, which is actually a stereoisomer progesterone, or the Mirena coil. Avoid using Provera or norethisterone. HRT is not a contraceptive, but most hypogonadal women are anyway infertile. So other sexual health issues in women with diabetes, antidepressants can delay or prevent orgasm. Candidiasis, more common with SGLT2 inhibitors, can cause dyspareunia. Hyperactive sexual desire disorder is more common in women with diabetes. There are issues with self-image, fatigue, dependence on others. But depression is really the biggest risk factor for sexual dysfunction in women with diabetes. There are some evidence suggesting a response to low-dose testosterone, but the guidelines recommend really that you first optimize the synthetic HRT and also the vaginal HRT. Do the simple stuff first before you start thinking about adding testosterone. And really, this is your most sensible overall strategy. Simple, 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 risk-free, risk-free, risk-free. I'm not going to repeat those 3 words over again. So, conclusions. Exploring and managing issues of sexual function is core to the long-term management of patients with diabetes in women as it is in men. Intelligent use of antihypertensive drugs can make a significant positive impact on male sexual function. Hypogonadism is greatly underdiagnosed in diabetes clinics due to not fully exploring non-sexual features, including anemia, as well as sexual symptoms. Normocytic anemia supports the diagnosis of hypogonadism in man and also predicts a better clinical response to testosterone treatment. Testosterone treatment at the moment is not often adequately targeted towards those men who are most likely to benefit from it. And both SGLT2 inhibitors and antidepressants give rise to both opportunities and challenges in managing HRT in men and women with type 2 diabetes. So many thanks for listening in, and I'm open to any questions. Thank you.
Thank you so much. Can we have expert opinions very quickly, please?
Thank you, Richard. I think so, as always, and very elaborative and excellent talk. And this is one of the area where in our part of the country, we usually not talk with the patient about it. And majority of them, they've got the real issue when they've got a longer standing diabetes. So I think so, very well elaborated, very well taken. Thank you very much.
Thank you for being able to express it, Richard, so easily. A very complex topic in a very simple language and terms. Thank you very much. Two things that I liked.
Silver Fox, I love you.
One was the fact 9 a.m. testing and the post-lunch effect on the gonadotrophins and the testosterone. This is something which is very useful for us, especially those who are managing it, even for those who are not endocrinologists. Thank you for sharing that.
Thank you, Richard. Very comprehensive. So I'm not sure how much is stored in the minds of the people who are hearing, but this is very, very important topic and often ignored. So for the sake of all those who are sitting here, a patient with diabetes complaining of symptoms, FSH/LH normal, T is 300 or 350. What would be your advice?
So I would say that my advice will be lose weight, improve glycemic control. The only thing that would prompt me to start to consider testosterone treatment in that situation would be if they were anemic, or if their sexual function was absolutely refractory to treatment with the Viagra or other drugs. But for me, what's really going to predict the response, a good response to testosterone in somebody with like a borderline level, and you think it's related to chronic disease, is low hemoglobin hematocrit. You are not going to increase their cardiovascular risk by treating them. You're not going to reduce it. You're not going to improve their glycemic control. The improvement in sexual function could well be very modest. It may be real, but it may not be significant for them. You know, if you're not able to get an adequate erection, then having an extra sexual thought per week may not be enough to make a difference. And you will increase their risk of fractures, not fragility fractures, but activity fractures through mechanisms that we're not quite sure about.
So many of these patients are in our care for the last 5 to 10 years. And they say, I was same weight, I was diabetic, but that wasn't there. Can't you help me at all? The first help we give is the PDS inhibitors and try. But if they don't respond, how long to wait or to give a trial? I sometimes end up giving a trial to see the result.
Well, you'll know very quickly whether a PDE5 inhibitor doesn't work, and you'll know within about 6 months whether testosterone has an effect. They will often get an initial kind of almost like placebo effect of starting it. But by 6 months, you'll have an idea whether this is really sustained or yes or no. In most cases, it will be sustained, but it probably will not be significant enough to make a difference.
And if we have got time, one last question. What we call secondary hypogonadism. So testo is low, FSH/LH is normal. Have you tried giving clomiphene to these patients?
Yes, I have. And either clomiphene or actually aromatase inhibitors such as anastrozole, that will put your testosterone levels well up in the normal range. The problem is that a lot of male libido is estrogen dependent. And so it doesn't help. Yeah, you normalize their testosterone, but actually the libido is not necessarily any better. So this is the paradox. You put the biochemistry right, but actually you haven't necessarily made them feel any better. Clomiphene is associated probably with an increased risk of thrombosis. So that's a concern in obesity. The aromatase inhibitors are associated with like loss of bone density. I think you might consider it if fertility was actively desired and they were unable to afford gonadotrophin treatment, but the evidence is not so strong, and there are risks either way.
Thank you.
Thank you so much.
Great questions. I tell you, the silver fox is
Thank you
on
so
form
much.
today.
Thank you so much, sir. Okay, so in the interest of time, we can have just one quick question. Yes, please. And please to the mic. One question, please.
My question is that in type 2 diabetes mellitus, obesity and metabolic syndrome is one of the major risk factors to develop diabetes. This hormone, testosterone, is a hormone that increases your muscle mass and it decreases the insulin resistance. Can we use testosterone as a treatment in type 2 diabetic patients?
So yes, but under two conditions. And this comes from the type 2DM study from Australia. First of all, using a really high dose of testosterone. You're banging in libido, testosterone under cannabis, 1 gram every 12 weeks. And you're making about nearly a third of the men polycythemic. And also it's combined with a lifestyle intervention. In that situation, Weight Watchers. In the UK individual patient data meta-analysis, the testes analysis, and also in the US prospective RCT Traverse, there was no impact in these overweight older men with slightly testosterone on glycemic control or on diabetes risk. So nice in theory, but in practice, it's not going to deliver.
We are at the end of the first session. And for the second session, I'd like to invite Dr. Amna Omar, and I'll hand over the stage to her.